this is just targeting the disc space here.
Oh, I think we have sound now. If we could just turn that up a little bit.
Disc space. Typically mark the midline and then go lateral. Okay, and then so here's the midline. Then get a lateral, and then we'll get a lateral to see what the Ferguson angle will be for our approach. Because basically,
hey Ashley, I thought you were going to give me the controls to this video.
As possible,
I'm not able to
in line
record it right now.
with this space so that we don't hit hand plates with our.
You have controls.
All right, thanks.
Okay, so it's pretty good. Typically,
okay. So this is a case I did about 3 weeks ago. Recorded for this since we couldn't do a demonstration in person. Right now, we're just showing.
We're
targeting the disc space here at L2, L3. This guy has a foraminal herniation above a previous two-level fusion. He actually had a T-lift at L4-5 like in 2013, and then in about 6 years later, he needed.
And that's the disc inclination line.
L3, L4 due to a breakdown, and then unfortunately now a year after that he's got a foraminal on the left side.
Okay,
L3. So
this one is pretty much straight up and down.
Your fusion, you're doing
foraminal herniation.
Discectomy.
I might cheat a little bit.
And you can see just kind of localizing our starting point.
Midline.
Kind of factors are you want to go lateral enough so that you get good trajectory.
There we go. Okay, so starting surgery on this patient. So our target level of L2, L3 on the left side. He has a foraminal herniation. His history of a previous 4-5 fusion.
Here's
13.
localized it.
2000.
And that size of skin here.
He had
the whole tract.
L3, L4 bilateral hemilaminotomy
Here's
due to adjacent level stenosis. And then he actually will do a.
So I'm going to fast forward to where we were. We anesthetize the tract all the way down into the foramen. You can see the needle. We're going parallel to the disc space. One of the things to do this safely and not hit the dura is just like when you're placing a pedicle screw percutaneously, advance on the AP and never go past the medial border of the pedicle with your
edge of the annulus
needle before you check the lateral. Here we're at the medial border of the pedicle in the disc space. You can feel the trajectory of the annulus if you're in the right spot. And then
usually on the AP, I'll advance.
Go to the lateral.
I get to the medial border of the pedicle. No.
Hey, Ashley, the controls again went away. I don't know what happened to the bottom there.
Go back to AP.
So you can see there on the lateral, it was right at the posterior border.
Lateral.
So essentially, we just want to get into that disc space, right in the foramen, right in the Camden's triangle, right in the axilla, basically, of that axillary nerve root, where your foraminal window is, bordered ventrally by the axillary nerve root and dorsally and superiorly by the undersurface of the superior articular facet and also the epidural space, and of course caudally by the pedicle and part of the superior articular process. So once you gain access there with the needle, all right, let's try this again.
We'll do it right there. Okay.
Try to get to. Okay, so this is just kind of showing the steps. Once you get there with
that's not bothering him.
All right, I'll rewind just a little bit more. We'll typically inject with some blue dye. Usually it's indigo carmine dye, and that helps selectively stain the nucleus.
Incision
helps orient you because the nucleus
size, and he's also
is stained blue.
Where that's not bothering him. We get this double obturator.
Once you have that guide wire in through the needle, then you start dilating obturator here.
And as I advance it, I'm twisting it so it goes in atraumatically. putting that right there on the annulus. Okay, that looks good. I'm also checking the needle. I'm going to back it up a little bit so we don't advance it farther. There's a second hole on this obturator where we can anesthetize annulus. Okay, I palpate medial, caudal.
And so with this eccentric canal, we can differentially anesthetize the annulus, and that also helps determine whether the nerve root is needed or not. So you can see if it's irritating, just so you know how close to that exit you are.
Portal's eccentric to the center needle. So now I'm holding this in place. I'll take out the guide wire and we'll advance into the disc.
Right here, we're then putting once we have the cannula placed, we'll put the endoscope in. And
in this place, in stained blue, I am going to.
So typically, if I'm going to go in the disc space for discectomy, I'll usually like to start in the disc and then pull out, because disc is home. You know, just like when you're doing a bone is home, and that kind of orients you. Your disc is home, and then you can come out at, from there. So this is just kind of starting and getting the
in terms of not just tell me what
focus all set. Start playing again.
Pull out any fragments. So this is a good view. This is showing there's some posterior annulus. You can see the white parts, and then there's part of the epidural space. You can see some epidural vessels, the red stuff, and then maybe the lateral extent of the ligament of flavum up at 1 o'clock. You see the yellow stuff. So here's some of the herniation, part of the foraminal herniation. It's back in. Grab that little piece that's floating around.
And also, just to note that the patient here is awake. We're just using conscious sedation.
You see the epidural space. You can see the epidural fat right there. Take a picture of that. Wait, hold on.
It's important when your anesthesiologist is doing that not to totally knock it out with some propofol.
Here,
so we will just use fentanyl so that he's awake and aware, and that way that helps prevent
pictures here. Grab this out of the way.
You retract the nerve too hard or grab the nerve, the patient will let you know. So that's your real-time nerve monitoring device.
Take a picture right there. Let's get view the epidural space. Take a picture right here. Okay. So that's in the epidural space dorsally. Just kind of spinning this around, looking. So now I would be looking towards the left where the nerve root would be. There's some epidural fat in the foramen.
So to orient yourself, 12 o'clock is dorsal to the left,
fibers,
cephalad, cranial, and then to the right it's towards the feet.
Lead. Use a bipolar.
It's towards his belly.
Electrocautery probe here. Eloquence. Okay, so little bleeders right there.
Fluid medium, so just like a knee arthroscope, you have a fluid medium going, and that helps visualization. Also helps a little bit with
rip and bleed. Pituitary.
And this is one of the most important instruments of endoscopic surgery is the Eloquence bipolar probe. So this
probe is very specific.
Hemostasis.
Energy.
And it also dissects soft tissue out of the way.
Up here on top, that's the undersurface of the superior articular facet. You can feel a little bit of bony resistance. I'm just kind of cauterizing some of the soft tissue off of there to expose that.
And it also protrudes. When you make it protrude, it curves. So use it like a nerve hook, like you would typically use in a microdiscectomy to palpate things.
The lateral extent of ligament of flavum.
It's a very nice tool. One of the workhorses of the
cause some posterior stenosis. Just kind of removing some of that. Okay, you can see that epidural fat is peeking in right there. So since this is a foraminal herniation, I'm just going to kind of work around here in the framing, pushing on this Penfield extension type. See, here's some of the annulus. Give me X-ray. Wait. Okay, now X-ray. Okay. Pushing on this almost like using a probe when you're doing a microdiscectomy, seeing if I can push out any loose unstable herniation. Okay, going into the disc a little bit. And then now just pulling back out. So there's some of that herniated fragments.
Let's fast forward here a little bit. So basically, you know, we're just working around in the frame and looking for that herniation. And it should be right here. So here's where we're just
Exing nerve root would be, but
in hemostasis.
Jump or anything.
Cannula.
That's a really important thing of keeping them
Actually has a nice
aware and awake.
Penfield probe extension.
Big piece of herniated
Here's
disc.
the big herniation. Here's the money shot.
Picture? Right there, right there. Okay, so now I'm going to pull this whole thing out.
So that was probably the biggest piece.
Probably the main culprit here.
The herniation right there in the foramen.
Right there at our entry point. It's nicely removed, unstable herniated nucleus pulsus.
There, so now you can see the annulotomy in there, and right now it's just a lot of my dad was
probe.
picking cotton, picking out a lot of the loose unstable disc right in the foramen. I'm going to fast forward this now. Basically, we'll just be turning the cannula around there and looking around the foramen, trying to get more disc out. And so here's some more disc right there in the foramen. We're pulling it out. And just cleaning up and making sure that it's all decompressed.
So we got everything that we can see really quickly in the frame.
It's also notable that we have this endoscopic pituitary. It goes down the scope through the working channel, and that way you can directly visualize what you're removing.
Grab that, turn the water flow down. So
about a 3 millimeter or so pituitary. If you take
so I'm going to position this cannula.
Discs, or if you take out the endoscope, then you can use larger pituitary.
Epidural space in the plum. Endoscope, I'm going to use these larger pituitary rongeurs, which are called short fat pituitary.
And you do this under fluoroscopic guidance.
Fluoroscopic guidance.
After the cannula is positioned safely right at the edge of the annulotomy.
Yes, I'm right at the entry zone. And just kind of grab the fluoroscopic guidance with these bigger instruments. Okay, give me the long fat, which is the
shorter pituitary, and the longer pituitary, which gives you a little bit more reach. And then the next one will be this angled pituitary, which is fondly called the grabzilla.
This is just reaching into the disc space. And so here,
show you how it works.
See, right at the entry zone.
And you don't want to do a total nucleectomy here. And here's the grabzilla. See how it articulates?
Angled pituitary. Go in. It's got a nice design there.
So Chris, you're really working within the disc right now, correct?
A little bit more prominent.
Right at the edge of the disc. So you don't want to place this pituitary all the way through. You kind of want to get it just as it exits the
forceps portion
cannula, because you're not trying to do a whole nucleectomy. You're trying to get it at the entry zone, from, right outside the cannula. So here's how you know that. You basically will
getting all the loose and stable.
Open up until it exits the cannula. And you can kind of feel without taking so many shots.
Blue, nucleus.
And then you kind of get a
do it right at the entry zone to the frame. So I'll have this compressed so that it's not open. And then when it opens, I know I'm just right at the edge of the cannula. You can see that. It's a little bit past. And I'm not trying to do a total nucleectomy here. I'm just trying to get the herniation right at the site. So let's take a peek right here.
Okay, and then so after you do that, then
how do you know when enough is enough, Chris? How do you know when you've done enough of a discectomy?
Yeah, so it's kind of routine for me. I'll go in and do the visualize part with the endoscopic forceps and then get as much as I can. A lot of times we get everything at that point. And then when I can't get, when I've gotten as much as I could just from that view, then I will do what I just did there and use the larger non-endoscopic pituitaries. And that can often grab some bigger fragments that are a little bit harder to grab with the smaller pituitaries. And then I'll come back in and look around and, just try and correlate with the preoperative MRI based on the size of the herniation you see on the MRI and the location, and then visualize that location where the herniation was on the MRI and make sure that it's free of disc tissue. So now, after we've kind of done the pituitaries, we're going back into the disc. We'll look in the epidural space and we'll look in the axilla of the nerve roots. So certainly if it's a foraminal herniation, you're going to want to try to see the edge of the nerve root and or the posterolateral corner of the cephalad vertebral body. If it's a paracentral herniation, you'll want to see the traversing nerve root and epidural space. So here you can see I'm probing up into the epidural space cephalad. You can probably see it. I'm way up, probably like a third of the way up on the vertebra. So if you had a paracentral herniation here, you'd go up there, sweep, and make sure there's nothing there anymore. So that's just like a regular nerve probe and a microdiscectomy. Here I'm going caudally now, just kind of showing, this wasn't a paracentral herniation, but I'm just trying to demonstrate how you can use the
this space and just sweep
and go cephalad caudal and also dorsal
not pathology in the space. So I don't necessarily need to do that.
So there's a question from the audience saying that the intradiscal dye injection, does it help in extruded or free fragment identification?
It does. And, sometimes you get this patriotic fragment because you get out a fragment that's red, white, and blue. The blue stained portion is the part that was inside the nucleus. The white stained portion is the one that was trapped in the annulus, and then the red stained one is the one that was the part that was extruded and vascular. So
right there
can help.
The surface of the superior articular facet. Give me a picture of that.
So here, at 12 o'clock, you see the
laser
undersurface of the superior articular facet and the facet capsule. And so you can see I burned it a bunch with the
laser. It's very specific.
Eloquence
use this, but it's really nice.
And this is causing foraminal stenosis. Again, the Eloquence with a frequency probe is the workhorse, but it's really nice if you have it and you have the luxury is a side-firing Homium YAG laser. So, we're going to show you here how nicely and precisely this can dissect soft
laser
and foramen.
The red dot.
It also can remove bones. Here it is like a laser sighting. And so the plates, and only the plates where the laser is.
Now it's just stripping off that soft tissue. It'll even remove some bone.
So again,
sort of like a half crescent.
Typically, we'd use like big Keras or you can use here also. But this is such a nice, precise tool, and you can put it right next to the nerve root and shoot right next to it, and it doesn't.
Just enlarging the foramen. See how that's nicely moved that? I'm going to go in a little bit more.
That's the undersurface of the superior articular facet and the facet capsule, and then also some of the lateral extent of the ligament flavum, which is medial, and we're just working towards epidural space and the
how nicely that's working.
Nerve root.
So again, this is not what we'd say, hey, laser surgery. You know, this is just another tool to help accomplish our goal of decompression.
And use a laser only because it's harder to use the bigger
really
tools.
nice high-tech one, but again, not totally needed, but
it's really just a luxury.
Much more efficiently for certain things like this.
I'm going to fast forward this a little bit. And so it's just freeing up the epidural space a little bit more. I'm going a little bit more medial. So I'm into the lateral recess right now. So he had a little bit of stenosis there, patulous facet capsule. And you'll see the the traversing nerve root here pretty soon.
There's another question from the audience, Chris, saying, have you used osteotomes or chisels to trim the facet?
What was that again, Jeff?
Have you used an osteotome or chisels to trim the facet?
Really nicely right here. Give me an extra picture right there.
It would be not necessarily an osteotome, but it's what we call a tree-fine. So it's a circular, and we'll use that. So here's that traversing nerve root, nice and free, as you can see.
Okay.
So just looked at that. I wasn't so concerned about that one because it was more the root compressed in this gentleman, but I was just trying to show the anatomy that you can see.
Now, let's go look in the...
So now here, since it's foraminal herniation, you're going to look more into the foramen. I'm going to try fast forward, and sorry guys, I'm going to miss a little bit here. So the extensor nerve root should be here on the left side at about 9 o'clock, cauterizing around it and trying to retract around it. Since he is awake, you can poke at the tissue there, because a lot of times it's just the epidural fat is surrounding the nerve, so you can poke it and see if it hurts him. If not, then you can hit the electricity on the bipolar, and so that's what I'm doing right here. Nicely, he didn't ever have any nerve pain. So looking left where the extensor nerve root is, there's some epidural fat around that nerve root right there. Using that Penfield type extension here at like 7 o'clock, using that to retract. Epidural fat. I'm trying to just verify that we got decompression of the extensor nerve root. And he had a lot of epidural fat and fat around the nerve root here. And you can see that right there. You don't really see the nerve root perfectly. Maybe a little bit right here is the nerve root.
I'm looking right there. So get a picture of that fluoroscopy is where I'm looking.
So here's where we're positioned, looking right at the extensor nerve root. We're extraforaminal at this point. And you can sign it right there at like
right here.
7 o'clock, 8 o'clock. Here I'm probing where the nerve would be.
No, yeah, okay.
Capillaries that you ablate. Here I'm going to fast forward this a little bit. We're just dissecting. I'm slowly working from the annulotomy towards the exiting nerve root to verify it's decompressed. And I'll expose a little bit more patulous annulus. I'm going to go a little bit faster, 5 times.
There's all that stuff.
And I'll just keep it on 2 times right here, because basically as we keep working towards the exiting nerve root, you can see the cannula there. Just really trying to verify that the exiting nerve root's free. You'll see that I dissect and find some more patulous annulus and some of the herniation. And then also start removing more of the undersurface of the supraarticular facet, which was actually causing some foraminal stenosis. So let me just fast forward even faster. There's more disc tissue. I'm just grabbing more disc tissue. There's sort of the fat around the exiting nerve root.
As paraforaminal stenosis. See anything?
Okay, I'm just trying to, I know my time is up or getting to be up. So we're going up there to left into the axilla.
It's a little foggy, so go ahead. Yeah, let's help.
So you can see here, this is kind of nicely visualized, going towards the tip of the superior articular process, and we'll use the laser.
Fog this. There we go.
To start removing that and expose it and alleviate that kind of like that pinching stenosis right there. So this is kind of nice where you're showing the laser getting right next to the nerve root and using it safely.
Okay, right here is where I want to.
And that's really the tip of the superior articular process right there.
The nerve root on the left. Giving my laser to the right.
There's 8 more minutes to this video, but I'll fast forward it a little bit more, a little bit.
This whole piece. Trying to ablate this.
I think we got to start wrapping up here, Chris.
Yep. This is just a good piece where you're looking at the laser working. And then I'm just gonna fast forward. Working towards the nerve root, shaving off the tip of the SAP, nicely dissecting it. And then you can see it's more decompressed. Going to epidural space, again, just making sure that stenosis is decompressed. And then I'm gonna wrap this up and come on out. At the end, we'll typically, got 40 seconds here. Oh, well, so then you're done, and you basically inject a little bit of depo afterwards. And then
Put some serious
I'll show you all this tissue that we removed. So that's the disc tissue removed. So
it's a lot of disc.
Right. That's all done. It was a little struggle, but got through it here.